So thank you, Dr. Amanda Cuda, for joining us today. Most of you know Dr. Cuda, but I will go ahead and introduce her today. Dr. Cuda joined 98.6, a virtual primary care company in 2017 as one of the company's first practicing physicians. She joined the team after 12 years of active duty service in the Army, which she served clinically, academically, combat operation, and leadership roles. Dr. Kuda's thread connecting her work has been developing and sustaining quote unquote life in medicine by cultivating physicians from all specialties in all stages of their career. And this has led to her original role of medical director at 98.6 and now a physician for product innovation and strategy at the company. Um, she also follows this thread by continuing to serve in the Army as a in the U.S. Army Reserves at USU as an assistant director for family medicine and admissions/recruitment. She integrated medical innovation work with curriculum development at the UME level by building and implementing advanced clinical rotation at 98.6, emphasizing health systems science competencies. Dr. Kuda is a family doctor, as you all know. She earned her BS in biology from Wheaton College, her MD at USUS, MPH at University of Washington, and faculty development fellowship at Madigan Army Medical Center. She's a wannabe homesteader. She lives in Gig Harbor with her husband, Scott, who is also a USU grad and Army pediatric urologist. And they have 4 amazing kids, a sweet black lab and 2 kittens. So I will hand it over to Dr. Kuda, and I will monitor the chat box for any questions, or you can wait until the end to ask Dr. Kuda. Thank you.
Thank you, Winnie, and hi, everyone. And of course, it's always that interesting experience of doing these virtually. This is a conversation that I will invite you to. And as is my presenting style, I will have various points where we'll be answering questions. So if folks want to turn on their video so I can see your faces, because I can actually, I have both panels going, I would invite you to do that. And I can see if you have a piece of paper that you can write some of these answers on. So, but we'll go ahead and get started. All right, as Winnie mentioned, this is who I am here at USU, and it is my part-time work as a reservist with all of you. There's a concept of a work rhythm described as an 80-20 rule that you might have heard Dr. Chimino speak at the USAFP around. And I've really engaged this in my work at 98.6 as well. When we can do 20% of our work that really inspires us, it ends up sustaining the other 80% that is often our toughest work. And let's just say my USU time is my 20%. So I'm really thankful to be here with all of you today. This is also me. I wear a lot of hats, and it's worth stating that my entire professional journey has been an iterative and innovative experience, which is product or tech speak for I haven't quite gotten it right the first time, so I usually just keep trying. And I'll speak more about that in a few slides. But first, as you can tell, I have a full-time job with a startup company, and I'm still working with USU and the US government. So I do have some disclosures and disclaimers to lay out there. And that's all that said, these ideas are my own and have been built over time with the help of many teammates over the years. These objectives will offer you a bit of what we're going to cover today, but I'm also going to say what we're not going to cover. This was a tough presentation to build because I did that learning needs assessment, which I appreciate everyone contributing to, but it didn't actually listen to it very much. I was reflecting on a tenet that I try to adhere to when I teach is that it's hard to present on something that you don't feel truly inspired or competent to talk about. I can't even pretend to describe the evolution of the MHS genesis. And honestly, it's probably not that practical for many of you yet, unless there are a few folks from Madigan that have hopped on or other West Coast locations. And those folks probably need some support group sessions more than anything anyway. So we won't discuss the current state of MHS and EMRs. I know many of you also have the impression that I'm an SME in the delivery of care via telemedicine. I do that every day, yes. And the work that I do with patients is actually text-based virtual care. So it's an interesting variation of the telemedicine scenarios. And I do lots of physical exams via video, especially with kids. And I can certainly confidently describe tips and tricks, but I'm not going to commit our time there either. Many of our team members at USU have spent a lot of time building tools and materials for the delivery of care through video-based telemedicine, and they're really your SMEs. I do have a favorite list of resources where I go for learning, including Hippo and Aquifer, and they have great future and current resources available for telemedicine delivery tips and tricks. So that's all I'm going to say about that. What I do promise is a high level overview of telemedicine, virtual care, and clinical informatics, and how those are intricately connected with the evolution of health science, health system science curricula. And I also promise you, which might be a surprising link, is the personal application of the discover, design, and delivery cycle of product user experience research and design. I'll start us off with my answer to the warm-up question that I posed earlier, and I look forward to hearing from some of you at the end. So here are a few definitions just to get us on the same page. Working in a digital healthcare startup for 4 years, and especially in product medicine for the last 6 months, has exposed me to a whole new language. And this language might be familiar to some of you who have worked in spaces of product management or engineering. These terms are specifically applied to technology products. And the most surprising piece of the work that I have found is that behind each and every app that we use in our day-to-day life is a very organized system that spends time discovering and designing each system before delivering it. And that includes an army of engineers, not the Army Corps of Engineers, but literally lots of engineers who code each conditional step of this system. It's pretty amazing to consider what goes into our technology. So when I was 8 years old, I remember riding bikes, exploring the woods near us in the Adirondacks and building forts, playing with friends, creating extensive social systems that we would build out of toys or Legos or whatever. I loved to read. I liked school well enough, but I loved going to church. And I grumbled when my mom made me work in her garden, but I can remember her gardens in very great detail. For those of you who know a little bit about me, none of this is likely surprising. I have some pretty strong roots in engineering and innovation. My dad's a biomedical engineer, and he's sometimes called the grandfather of the endotracheal tube. He actually developed the King LT among many devices prior to that. And I had the opportunity to use his airways when I was deployed to Afghanistan. So it was a pretty great connection. I am a family physician, as you all know, and early on, I adopted the innovative mindset of the biopsychosocial model, which is not just for our patients, but for myself. And having a network of teammates has always been my inspiration for innovation. And you might recognize a few folks in all these photos. My role working in virtual primary care happened fortuitously. I'm not a software engineer or product manager by training. I didn't even major in biomedical engineering. And though people might think I am, I'm not even that tech savvy. And I would propose that all of you who maybe don't feel like you're that tech savvy, you can still be a systems thinker like me. And our clinical experience has obviously engaged the military health system. I've had some time in private practice environments and other civilian health systems, but it really does help us with this kind of idea of being a systems thinker that I'll talk more about. I was an early adopter of technology tools. I think there's a few folks that are probably of a similar cohort to me. I trained out at Tripler, and we used to have these old CHCS consoles where we could actually create macros in CHCS. And CHCS is sort of the underlying technology for our current, sort of Alta that's still out there. Those consoles were only in the ICU and the ER though, so I would spend time on call creating macros to help me build efficiency into my coding efforts in clinic, back when we were doing the original 99213s and 99214s and kind of figuring all that out. I did have a PDA, and now I have just about every one of Doug Mauer's recommended apps that he shoots out there. And my phone, like many of yours, is probably my primary repository for my medical knowledge. It's definitely an extended brain. So one of the things that I had the opportunity to do before I finished on active duty was to implement a patient-centered medical home on one of the, or transition one of the clinics in JBLM to a PCMH in a soldier-centered medical home. And I had just completed my faculty development fellowship. So I had lots of ideas about how I wanted to do that and adopted the PCMH training tools and practice management strategy early. So I was able to contribute as an SME in Madigan's broad adoption of the PCMH integrated models for physical therapy, clinical pharmacists, behavioral health, care coordination, and case management. And all of these things are now foundational to our primary care health system, but they weren't for, all of our careers. So this is something I've really been thankful for being a part of, having these as part of my roots. Oh, and of course, now I'm going to have to reload. Sorry. It was going to happen inevitably at least once. Okay, let me switch back. There we go. Okay. So of all the innovations that I've envisioned, explored, and operationalized, I would say they have their roots in my military medicine work. But I've learned the most through being a mom, being married to a USU grad, and being a gardener. All right, on to some high-level details, what you all are excited to learn about, I'm sure. So the terminology digital health technology is actually used to describe any domain where technology is applied to support the health system. And this can come in a variety of forms, as I've offered here. Interestingly, a study done in the American Journal of Medicine, which was just in January of 2021, presented that patients' usage of online searches for health information increased from 49% to 55% just in the 2011 to 2018 timeframe. Now, they didn't even report on what has happened in the last year, but what we can all imagine is that even just the online searching for health information has exponentially increased, let alone the access to healthcare delivery through telemedicine options. I like this definition of telemedicine from Connected Health Plus. It highlights the benefits of telemedicine solutions, including those we've experienced in COVID, and many of you have already become experts in. The ability to interact with the patient synchronously, but not in person, and beyond the telephone has opened up huge possibilities, especially for populations that have limited access to care for a variety of reasons. Maybe it's a rural patient, a patient located in a rural environment. Maybe it's someone who has limited mobility. There's lots of reasons why telemedicine has been adopted by a variety of populations. We do know that there are limitations that we've already seen of this transition. And this includes the idea of maybe fitting this into our current model. So telemedicine has not changed probably most of your days in how it's structured for your clinic. And I would suspect that other than interacting via video chat, you probably still have a pretty typical clinic schedule and daily appointments. So this definition of virtual care is actually my own and is a preferred term for the type of practice we're building at 98.6 and many of the virtual care companies that you all have maybe heard about. Our goal is not to add a video into a typical clinical encounter. It's actually to intentionally consider how technology integrates and facilitates the process of the goals of achieving all the aspects of the quadruple aim. So high quality, low cost, a helpful experience and patient-oriented outcomes, and then the clinician and care team experiences that are sustainable. The clinical informatics is a discipline that we train for in the military. As many know, Madigan actually has a fellowship that's led by Dr. Bob Marshall, another family physician. Its focus is on information in particular. So the orientation of clinical informatics is electronic health record development and usage, And so you can see how each of these terms has a huge amount of overlap, but also some pretty significant differences. This slide offers a perspective on the nearly 150 companies that were involved in some form of digital health technology in 2020. It's sort of mind-boggling, actually, because this is even out of date now. The 2021 sort of similar concept diagram hasn't even been developed yet. A projection of $26 billion is set to fund global healthcare tech just in Q1 of 2021. Again, sort of mind-boggling how much money is, kind of being invested in this space. This is a 2% increase from just Q4 of 2020. So COVID has rapidly catalyzed a change in this aspect of the healthcare ecosystem. And many folks are suggesting that this will have a pretty significant impact on the healthcare ecosystem as a whole. And this, obviously, these companies aren't just folks oriented towards primary care. You can see from the schematic that the application of technology is across domains, specialties. It engages everything from data sharing, interoperability goals, to digital therapeutics, and then the actual healthcare delivery. Some notable mergers and acquisitions have occurred that will have an impact on primary care delivery. Behavioral health care access is being rapidly expanded through many of these models and platforms. And then regulatory flexibility during COVID has offered the space for many of these innovations. And it may lay the groundwork for broader changes in healthcare delivery. But many of these innovations, while they'll be amazingly useful for expanding access, lowering costs, and elevating quality of care, there still are a lot of questions that arise from these trends. And many of you have probably thought about those as I have. This schematic is hot off the presses from an article by Joe Connolly in his blog yesterday. And I'll shoot the link if folks are curious. And I would be remiss not to offer this trend that has been presenting itself in the ecosystem. This is referred to as the virtual first ecosystem. And in 2020 alone, as I mentioned, we've seen some merging of players like Teladoc and Livongo, Grand Rounds, Doctor on Demand, and Cigna with MD Live to kind of reveal some of the evolutions that may impact the ecosystem related to this. And you can sort of see the idea that for payers in particular, there is some energy around having folks access a virtual option first, and then having that help to facilitate getting patients to the right place at the right time. So there are some familiar ideas here to our patient-centered medical homes. But again, this is a sort of new trend that I wanted to make sure that everyone was aware of as a result of our conversation. Now, on to health system science. And I would venture that our best way of analyzing the trends that are happening in our environment is by using a lens of health system science. Many of you have been, like me, a part of USU's efforts to build out the health system science orientation and longitudinal curriculum. And it really is a foundation, and the AMA is calling this the third pillar of medical education. So it's certainly an emerging area for focus, and many of the learning objectives of the health system science are going to intersect with technology. So the healthcare delivery and process, healthcare policy and economics, clinical informatics and technology, population health, value and healthcare, patient safety, quality improvement, teamwork and collaboration, leadership in healthcare, systems thinking, and complexity science. It really is all, overlapping, any of the efforts that we see happening in our technology space with this health systems science curricula. So I have really engaged with this and actually took on a bunch of the tools from the initial USU offerings with the students. And I actually learned a lot from those efforts that we, especially this past fall, kind of engaged with initially. So if you could imagine a system where we could standardize our clinical approach through the implementation and maybe automation of some of our longitudinal care pathways, following well-designed models, integrating clinical information systems, self-management support for patients, intentional delivery systems designed to incorporate care team managers and coordination of care. A system like this would allow us to deliver holistic and high quality targets that we've set for ourselves as primary care providers, and not just in digital primary care, but I would argue in all parts of healthcare. So it's a pretty inspiring space for me, at least. I particularly liked the USU cases. There were a couple case studies that I got to facilitate. One of them was in the clinical informatics, and they were talking about kind of the bad data in, bad data out. And we think about that a lot with my teams around this idea of standardization and bias. So there's just so much sort of integration of this learning across a variety of places. So we have to start with leading ourselves in this work, though. I would suggest that there is a space where we need to continue to be systems thinkers in order to be aware and continue to engage with the ideas that are really evolving in our ecosystem. In family medicine, we understand systems and we're naturally systems thinkers. Many of you have been trained in lean methodology or maybe have read Peter Singer's Fifth Discipline. And all of this is kind of consistent with that type of language. Many things have kind of come back around. This is the list of the habits of systems thinkers and tools that make these types of practices really accessible. These are the Water Center for Systems Thinking that we were given as part of our health system science courses this past year. The students use these, and many of us sort of helped walk them through some of these tools and habits. But have you considered that these are habits that we all still need to practice as well? I have been so challenged by many of these habits and practices for my own life and practice of work and life. And they're so consistent with things that we teach students, but how do I practice these as well? So let's do a quick, I like to pause now at this point. I've been talking for quite a while. I want to make sure everybody has a moment to sort of write a couple things down. So let's practice something quickly that you may all be familiar with, but the way that it's termed in the Water Center is this causal connection circle mapping. So if everybody wants to just take 1 minute and draw some causal loops around, or if you have a dry erase board is obviously my favorite method of doing this exercise. But draw some causal loops associated with the biopsychosocial connections of diabetes for a patient. And this isn't for sharing, it's more of just it's just a mental exercise, give you sort of a little moment. Somebody with their video on, look up at me when you're done. So I'll make sure that y'all have enough time. Dr. Liggett is super fast at this. He's a systems thinker expert. I see it.
Or I'm not very deep, either way.
And if anybody's brave enough and wants to lift up their paper and show us what it looks like too, that would be awesome. And I promise it's not a test either. This is purely an implementation task.
Andy, we're doing concept maps with the students early on, which is somewhat similar to this, to
yes,
them as this as an option.
Yep. And it links with, again, the tools that they're being offered through the health system science. So this diagram is actually from their tools list. So it's good stuff. Okay, it's been about a minute, so even if you don't have all of your loops drawn, that's okay. It's just more to sort of show that you all are already, you all probably do this already. Again, as Jeff mentioned, this is something that we're sort of trained to do and think through, even if we don't necessarily always practice it. So these were things that I was doing before I even started the work at 98.6. Okay, we're going to take a quick video pause here. This is great teaching from Pixar. We're going to watch this clip from Ratatouille, and I would like you to pay attention to Remy in particular as he presents his new idea to his brother Emile. Ratatouille is probably my favorite movie of all time, so thank you all for humoring me on that one. We, don't often sort of think about innovation, and that is where we're going to kind of transition a little bit here too, and it will connect, though you may not feel like it entirely does. And based on this video and this quote, I wonder what sort of thoughts might be generated in you and how you might think that this all applies to systems thinking and Ratatouille. I will tell you that this quote was stated by Ed Catmull, who is the co-founder of Pixar. And I don't know about you, but at least for me, making mistakes is actually not what I'm very good at. I actually don't really like making mistakes, and I definitely don't like making mistakes and then having it miss to a lot of people. And I would suspect that those of us in healthcare, especially in certain perfectionistic professions, really don't like making a mistake because we perceive that there might be life or death consequences associated with it. But how often has a perceived or an actual risk of making a mistake diverted you from an action? And how often has this approach to getting it right been generally okay, except that when it keeps us from trying something meaningfully different? I'd like everybody to just take a minute to write down an example of a mistake that you made that might have actually resulted in an innovation. And if you can't think of anything from your experience, that's okay. There's lots of historical examples that you could write down and think about. And it doesn't have to just be in medicine either. All right. I bet we've got some good examples out there. And like I said, I'm saving some time at the end so y'all can share some of your reflections because some of these stories are really good to learn about each other. So for me, I actually have a quick montage of examples where I was able to innovate, and sometimes alongside of many of you. I just like having the opportunity to show pictures if y'all haven't figured that out. So as I mentioned, this whiteboards are definitely been a part of my life as an innovator. And I tried out having a scribe work with me in private practice. And interestingly, she went on to UW as a medical student, took an Army HPSB scholarship, and she's going to be training in emergency medicine next year, actually. And I have no idea how she might have gotten the idea to join the Army. For this one, I just wanted to show this picture because it's Dr. Jennifer Chang way back in 2017 with Adam Kowalski as a way of celebrating a lot of the work that she has done in education and all of you have done, where I have been able to join in. In this situation, we were reworking the family medicine clerkship orientation, which again has been sort of iterated multiple times. And all you need is a whiteboard, a smartphone, and an orange, and boom, consent and skin procedure simulation. No need to worry that these students are distracted on their phones. They were actually asked to use their phones to write their notes. So these are just some fun photos for memories there. And then this is just a couple of additional photos of favorite educational innovation experiences that I've been a part of. And it's just a reminder that innovation comes in lots of forms. It can be technology, it can be devices, but it can also be educational innovations. And that's what many of you are involved with and is amazing for me to be able to share and watch. At 98.6, I have implemented some culture and leadership innovations and was a part of scaling our team from 7 physicians at its, infancy to 50 physicians now over the course of, about 18 months. And there's lots of stories behind that, but it's something that I feel really proud of. And this is a picture of my team back in 2019, the last time we were all together, because we haven't been able to get together since then with COVID. So bringing it even closer to your life, I'd like to even ponder how these concepts might apply to your work and life. Are there causal loops and cycles that might even apply to bringing in some of the questions of your work and life integration? As Winnie mentioned in the threads that I do with work, I can't help but sort of see this thread everywhere that I go. So I'm going to challenge us to bring this really down to our life. So we started really high level, and this is now going to come down to kind of even our individual perspectives. So obviously I wouldn't ask the question if I hadn't made that connection. And I mentioned user experience research and design thinking early on as a component of the product management, discovery, design, and delivery cycle. I've learned a lot about user experience principles from 2 books. One is called 101 Design Methods and Designing Your Life by Bill Burnett. And I suspect that all humans could use the permission to approach their lives from UX principles, like making mistakes that lead to innovations. Our process is nonlinear. Our process is iterative, but especially physicians. We start with asking about our targets or key values early on in our lives, but then we have to kind of keep thinking about that. We have to practice observation over time, also known as reflection. And we have to build our life and systems thinking through a group of people who can help us sort of make connections. This has been my full-time job for the last 4 years. So I certainly wouldn't expect all of you to be interested in all this content, but these are some of the books that have been most impactful as I've contemplated the intersection of technology, health system science, and primary care delivery. And all of these slides will be available for you as well. For additional resources that I have learned a lot from around the subjects of telemedicine tips and tricks, as well as systems thinking, I'll call out Matt Hawks, first of all. I'm not sure if he's on the call yet, but he's certainly been a part of multiple efforts to build out the USU telemedicine curricular efforts, as well as the STFM. And these are additional resources that I have found. And this is definitely an area of collaboration. Many universities are building similar curricula to what USU has been making efforts towards. And again, the STFM has certainly got a repository for a lot of those efforts. So here is our call to action, which is essentially, if you haven't heard it loud and clear, is to practice systems thinking, whether it's in our health systems, in our lives with students, or in our own lives personally, and how we figure out how to live our work and life integration. We can find causal loops just about everywhere if we would just look for them. So at this point, we've had a lot of opportunity for reflecting and writing down some ideas. So I would first be interested in having a couple of people share what you were like, or what did you do and think about when you were 8 years old, and how that might connect with what you're doing today, if you can build out some of those connections like I did. And for those folks, I will actually, let's see. Yeah, so we're onto our conversation point. I'm going to stop sharing so I can see all of your faces, in fact. And if folks want to turn on their videos, that would be even more awesome. And I do know some of you well enough to maybe even be able to say what you're doing when you're 8 years old, so I'll call on you, but I'll have uncomfortable silence for at least 20 seconds.
I can share. I don't know if it has any connection with what I'm doing right now, but as some of you or all of you know, I grew up in Ethiopia. So when I was 8 years old, what I was doing was totally different from what, you know, most 80-year-olds do here in the US or the you think. So I remember, you know, spend a lot of time playing outside with friends, like you mentioned, Mandy. And also my grandparents were farmers or still farmers. So I spent a lot of time visiting them and spending time on their farms, especially when the school is out during the summer. Would spend our summers on going to very remote areas. Remember picking coffee beans and harvesting corn and different things. So that was very nice. But I don't know, I can't really make any connections at this point, but
No pressure on that one, Winnie. I love those memories. When you figure out some connections, then you can, you know, let us know. Who else would offer up their 8-year-old story?
This is Milan. Can you hear me?
We sure can.
Okay, so I want to Winnie's memory remind me of mine as well. I grew up in Vietnam, oceanside, a lot of time outdoors. I love gardening and working with herbs and plants. So one of my dreams is to transition my practice to more telehealth so that I could be anywhere, needed outside when I'm working with my patients. So connecting my dream of the outdoor space and plants and herbs and healing in my practice. Thank you.
Thank you, Milan. You can come to my garden and share in my future outdoor practice that I dream about.
Acupuncture outside on a nice day.
I love it. All right, how about one more 8-year-old story?
Stacy, can you hear me?
We sure can.
It's funny, I was just talking with a friend about this yesterday because she boxed me and told me that her 8-year-old daughter wanted to teach kindergartners this summer. She was like, so Addie wants to do a kindergarten art class. She wants to get them all ready for first grade. She's been like on Pinterest and looking at like what sight words they all need to have down. And she wants to know if Katie wants to do it. And I just giggled because she's like, yeah, she's already made curriculum and lesson plans and stuff. And I just giggled because it reminded me so much of myself. And I remember that I had this deal with my teachers where in the summer, before the summer, they would give me all the extra that like purple ditto paper, like the Xerox like worksheets. they'd give me all the extra worksheets, and I would like divide them up and make them into like all the plans and the lessons. And then somehow like my neighborhood kids and my brothers would come to class, which I'm like, that's weird. But yeah, so I think, you know, teaching or wanting to teach or help was definitely coming out. And so it like makes me giggle thinking about another little girl who's like, you know, already well on her way. Who knows what she'll teach or how it'll work out, but it was fun to remember that.
Nothing like watching our kids at that age to sort of bring back those memories. And that I have a 9-year-old daughter as well. And I think that that has been a part of my reflection too, Stacy. I like that. Future educators. Well, thanks everyone for those stories. I am curious if anyone would be interested in sharing any of their mistakes that became innovations that you wrote down.
I'll go on that one. I'm sorry I jumped on the call late with another meeting conflict, but no, I think of I can think of probably mistakes in every aspect of my life. But one thing that I think of in making mistakes and innovations is in cooking, because inevitably, you know, something comes up and you didn't plan in advance to have the exact ingredient that you wanted. And so you improvise, or you accidentally bake it too long because you're on the phone with somebody, or, you know, or something. And sometimes, you know, that's resulted in a good thing. And then, you know, you were like, oh, well, I'll keep it in the oven longer next time. Or instead, you know, I'll use this alternate ingredient. And or, you know, maybe substituting healthier things than traditional unhealthy things. So I recurrently make a lot of cooking mistakes that sometimes results in a good innovation.
That's why I love Ratatouille, because I think that's like one of the best spaces as an example of this. Because yeah, historically, how many of our great recipes have been just as a result of, oh, let me just throw this in here and this in there, and what might have been thought of as a mistake. But certainly, you know, the stories about Thomas Edison and the light bulb and how he had to have, you know, I forget, like 200 iterations of it before he actually got a functional one. There's just a ton of examples out there. Did anyone else offer any other mistakes that were sort of innovative in the long run? One of my favorite terms that I've learned in the tech space is something called the MVP, which is not the same as what we all know of in sports. It's called the minimum viable product. And essentially the idea of it is that you have to start with something in order to get yourself moving. And it's been so often that I've used that with myself, because one of my hangups, you know, and many of you might relate to this, is that I sort of want it to be just right before I kind of put it out there. So it might be related to my writing or a presentation or whatever it might be, a curricular sort of situation. But there's something to be said for just getting it out there and then practicing and using it. And then that then engages this discovery, design, and delivery cycle. And you know, we kind of think about in the medical system analyses like the PDSA cycles or other types of safety and quality design methodology. And so just kind of thinking about our own lives, but then even what we're doing in medicine, kind of from that standpoint. And really, it's often what we do with patience too. I mean, how much of what we do is negotiation with them of like, okay, what's the minimum viable product here? Like we know we're not going to go this whole way of changing health behavior, but maybe you can take out your soda or whatever the negotiation is that we do with them. So it's a lot of application there. Yes, I love that quote too, Mike. Well, and I did want, oh, Frankie, did you want to jump in?
No, I was going to say your comment about that, which I thought you were trying to nudge us to give you more examples as the minimum viable product there. But I was also thinking, as you were talking about trying to get something out there and then working through it, is that actually takes a decent amount of courage and a willingness to be vulnerable. And I think and I think about our education space particularly, that's hard to do, because I think you have this, at least I do, I have this narrative in my mind of like, well, if it's not quite right, then they're not going to think I'm good enough to be here and do this, and have the qualifications or have done it the right amount of background, when really there's so many ways to make this happen. And this is one of them. I'm not sure if this is the exact right way, but we're going to try it. I think we've done that a lot. I mean, we've certainly demonstrated that a lot in this last year as we've been thrown into the environment we have. But I think the willingness to say that and do that, it really flexes depending on the situation and what you're giving and what we're talking about. So it's not always as simple as having a minimum viable product. It's like, what's the risk of showing that to somebody and someone saying you were supposed to already have more, in my mind.
Mm-hmm. Mm-hmm. Yeah, I think the academic environment, different than even the military, like I would actually almost put our true military operational environments more similar to my tech startup experience, where there's a little bit more of that acceptance of the kind of agility of doing quick iterations versus in the academic environment where, like you're describing, Frankie, I think the environment is much more of we really want it to look pretty good when you're putting it out there. So I think there are different contexts for that, but maybe there's space for agility in academics as well.
I think if there was, I think if we continue to do that, I think that it grows that space for that innovation. And that in fact, I have Dana in my mind saying, we just need to get this, ERB on paper, because we just got to get it going. Because if you don't move it, it doesn't have to be just right. It's going to come back to us anyway, as an example. But I think encouraging everyone to do that and say, it's not going to be perfect, because it just isn't. What it is, so is helpful.
Mm-hmm.
At least in this environment.
But it does take courage for sure. I bring it back to your original statement.
Yeah, this is Milan. I really appreciate bringing up vulnerability. And I find that, when we work with trainees and others, and even with our patients, we can open that door when we let ourselves be vulnerable with them. And especially in groups, we facilitate groups that we start with, something that show our vulnerability, and it just sets the tone at a different, stage. So I really love this discussion. I think so much needed in medicine. Thank you. Over.
Well, and I do want to offer the opportunity that if folks have questions about kind of the bigger picture arena as well, I'm certainly open to that. I wanted to make sure we had enough time for conversation and questions. So certainly we'll just take anything at this point, whether you have additional reflections or if you have any questions. We'll spend the next, or our last few minutes on that.
I'll start. I'm so embarrassed to tell you this, Mandy, but I learned about you working at 98.6. I knew you were in this arena, but I didn't know specifics until I read your bio for Grand Rounds. I'm like, I've known Manny Cuda, like we're in same circles. Your name's on stuff all the time, and I was like, because I mean that is a you know, in competition reports and stuff that I do with my work with Kaiser Permanente. 98.6 is a hot little item on the ticket that we talk about. And so anyway, I just I'm very curious at how you think. I know in our organization, COVID probably like shot us forward in a virtual first platform a decade or more. I mean, really just almost overnight. Do you feel that you guys have that this is how are you using COVID as an opportunity for your organization?
Well, and I'll just say I actually am happy to hear you say that, Stacy, because, when I'm in uniform, I'm very aware of the, sort of different faces of different things. So I'm perfectly happy to just sort of have been a representative of the virtual care environment and not necessarily specifically 98.6. I will say that our team has certainly engaged with what the virtual care first evolution it has been looking at. We have a partnership with Premera, which is one of the bigger health payers out here in the West, where this is sort of the target. The goal is to have patients sort of access us initially, and it's certainly, the pilot, sort of opportunity. And the biggest questions that I have in sort of our execution of this is how do we then continue to stay linked with the systems that patients are heading back into. And I think, again, that's where our interoperability and our data sharing and those sorts of things, as that expands alongside of this, which in that big concept diagram, there were a ton of companies that are sort of targeting that in particular. I don't think you can do one without the other and not end up in a similar boat to what we've been in, which is episodic care and not good access to patient information. So we're certainly, putting our toe into that water for sure.
Very cool. I'm sure I'll be hitting you up a lot now that your secret's out with me.
I have a question. Do you have any data or any studies have been done with patients, how they are perceiving this virtual first kind of care? Are patients excited? How are patients receiving that?
Well, and there's so many different levels of that. So most patients that access us are ecstatic because they don't have to go into a clinic. Like it just really kind of boils down to access. We're an on-demand service, which most, I think, similar situations are. So there's not having to wait, a couple of weeks for an appointment. So just that immediate sort of access issue has really solved a lot of things for the patients. And interestingly, I mentioned that we do a text-based format as our primary sort of communication. And that's one that has been really interesting for me to explore early on. There's data reasons for us kind of going that route, but what we've ended up finding that for patients, there are many patients that the anonymity associated with texting, especially in our culture, that actually brings people to actually say more about what they are looking for. Sometimes they don't always say it in the most respectful way. Like that's one of the things that's sort of losing that face-to-face that sometimes you lose. But, the teenagers that sort of like just text you, like they might be texting their, buddy or whatever. But, that's sort of like, to me, a low cost to the benefit of really getting at the information that the patients often are. We all know they sort of only give us so much information usually based on the trust that's built and that sort of thing. So that's one thing that's been sort of surprising to me in the text-based interaction. I do think that there's a big question when we start to get into some of like our automation and like interacting with different ways of communicating. Like all of us, you know, we have these apps where we're interacting with a bot of some sort, and you're always sort of like, is this a human or is this a bot? And you sort of know that it's probably a bot. And, you know, we're sort of starting to get into that space in medicine. And it's an interesting question as to how patients perceive that, first of all, how they receive it, and then does it matter? And we have a ton of our user experience teammates that are focused on that patient experience side that are asking all of those questions and exploring them. Thanks, Dana, for being here. Yeah, we'll finish up on time so we can get over and say bye to Christy. But yeah, it's a really great question, Winnie. I think that it's just one of these spaces where I have had to sort of like put aside a lot of my assumptions and sort of stay open and kind of seeing if things are the way that I've always thought they were. I've been surprised.
Well, thank you. If there is no last minute questions, we'll end here. Our next round is on May 12th. So look for email coming from me for that. And always, please complete the evaluation for this session today. Thank you, Mandy. And thank you everyone for joining.
Thanks everyone
Great talk.
for
Thank you.
joining. See you soon.